Welcome to our second talk in Access to Genetics Care for Underserved Populations track called Creative Strategies to Access Genetic Care Across Genetic Counseling Disciplines. Our speakers in this session are Emily Magness, a genetic counselor at Baylor College of Medicine and Texas Children's Hospital, as well as Lauren Westerfield, who is another genetic counselor at Baylor College of Medicine and Texas Children's Hospital. We are so excited to hear your conversation today. Please reference your screen for CEU accreditation and disclosure statements. There are no disclosures for these presenters today. And then on the right, you can see the learning objectives. Please visit the Continuing Education tab in the attendee website for additional information about claiming CEUs. And with that, we will hand it over to Emily and Lauren. Thank you again for joining us today.
Wonderful. Thank you so much, Blake, for that kind introduction. Let me share my screen. Okay, and Blake, just confirming you can see it?
Yes.
Okay, wonderful. So good morning and welcome to the session. I'm Lauren Westerfield. My pronouns are she, her, and my co-presenter is Emily Magness. Her pronouns are also she, her. So Emily is a pediatric genetic counselor and I am a prenatal genetic counselor. As Blake mentioned, we have no disclosures, and the learning objectives are both about identifying what the gaps are and talking through strategies that, while we can't fix the overarching system in which we're practicing, how can we as individuals try to manage these gaps for patients?
So to first start talking about gaps, I think we need to start with talking about where genetics providers are located and where can someone have access to a genetics provider. So on the left-hand side of the screen, you can see the map of genetic counselors per state in our Mountain State region. This is from the National Society of Genetic Counselor Professional Status Survey, and it's not broken down by specialty or anything, but just gives you a rough estimate of where or the number of genetic counselors that we have. On the right, we have the MSRGN map of genetics clinics. So this can include genetics clinics staffed by different providers, genetic counselors, geneticists, other providers. And this is also distributed across the Mountain State region, showing some satellite clinics, some are full-time clinics, and a variety of different specialties. So the big kind of takeaway here is that there are some geographic gaps in accessing genetic care. Most of the clinics and genetic counselors and geneticists are practicing in large metropolitan areas. And if we have to think about across the US, for context, there's about one genetic counselor for every 70,000 people and one geneticist for every 500,000 people. So obviously, not enough of us to go around to access the patient population. And to make matters more complicated, if we have to divide that out by specialty, the number of genetics providers differs. So for example, adult geneticists and adult genetic counselors make up the smallest portion of practicing providers within our genetic specialties. And so that means that across a person's lifespan, the access to genetics care might not be equitable.
So within that context, we wanted to make sure everyone was on the same page with when patients typically see a genetics provider. So there are genetic diseases that can first manifest symptoms at any stage in life. So therefore, patients can present for their genetics evaluation as a fetus, newborn, child, teen, or adult. They can also present for care in their reproductive years when planning for a pregnancy. However, transitioning between different genetics providers, different clinics, different life stages can be difficult. And so while this is not an exhaustive list, it does highlight some of the main categories of gaps that we see. So preconception, a patient may not have insurance coverage outside of an ongoing pregnancy, or their provider may lack awareness for the need for a preconception referral. During their pregnancy, they may have limited prenatal care, or they may have either a genetic or other condition that limits their cognitive capacity. We see gaps where diagnostic testing is not performed after a fetal or neonatal demise, or a pediatric patient is lost to follow-up after their initial diagnosis. Then getting into the teenage, young adult, and adult years, it's full of many transitions, such as aging out of CHIP or their parents' insurance, having to learn how to self-manage their care, maybe lack of education about the reproductive risks, and then, as Emily had shown, the relative scarcity of adult genetics providers compared to other specialties. We also practice in a healthcare system which is very siloed and fragmented by ages and stages, which is at odds with the fact that a genetic diagnosis has a lifelong impact on the patient and the family system. So, for example, a person with Marfan syndrome has different medical needs during their early childhood years and at their initial diagnosis than they do as they get older and age out of pediatric care. That same person also needs special medical attention when considering pregnancy or when carrying a pregnancy. They may either be the first person in their family with the condition, or they may have other at-risk family members who need their own evaluations. So rather than progressing in a linear fashion from one specialty to the next, a patient and their family may simultaneously be involved with different specialties within genetics, and the genetic providers working in these specialties may be co-managing different aspects of that family's care.
And we know that the transitions between those different specialties and life stages are quite difficult. As a pediatric genetic counselor, I have particular interest in the transition from pediatric care to adult and reproductive care. And in a well-known study that was done in 2018, they found that 83% of youth with special healthcare needs, which is often our genetics population, and 86% of children without special healthcare needs were not receiving transition medicine support. And there are a number of reasons for this and reasons why it's so difficult. There are just general systemic differences between pediatric and adult medicine. So it can be challenging for young adults to learn a new healthcare system, to find available doctors with their insurance, have different communications with their providers. So before, it may be the mom was making the appointments. Now the patient themselves has to call and make the appointment. And it also can just be difficult for patients to go to a completely new building or new place that they haven't been before. There are also cost difficulties. So financial barriers. Health insurance plans are generally more accessible in the US for pregnant people and children. And then after age 18, for some individuals, they lose health insurance. In Texas, for example, after the age 18, public health insurance becomes much more difficult to get. And Medicaid expansion is not available, or it was not accepted in some of our mountain states. That includes Texas and Wyoming in our region. So individuals with commercial insurance can also have issues where they might have very high deductibles and limited options for specialists. And then, as we've already talked about, there are just a lack of providers in general and specialists. So with all that to say, within the constraints of our current healthcare system, often genetics providers are trying to bridge those gaps to get people access to genetics services. And, we're going to share some information and cases that we have found where we've been able to bridge those gaps. And hopefully you too can learn some tips and tricks from this, or maybe you're already aware of some of the ways that you've been able to bridge those gaps. But it certainly can be quite challenging and even frustrating at times. And so hopefully we can provide some information to help your practice. So before we go into some of our case presentations, we wanted to give some context to our practice. So in Texas, genetic counselors do not have licensure requirements, and we cannot bill independently for our services. We also are not able to order genetic tests or other tests or make medical recommendations without physician supervision. Lauren and I both work at a large tertiary care center in a large city with a level 4 NICU, and we have access to geneticists and genetic counselors across all those different life stages. Lauren primarily works in our prenatal genetics space, where she sees individuals from preconception to delivery and works with a multidisciplinary clinic and fetal center with maternal fetal medicine specialists. I work on the pediatric side, so I work primarily with medical geneticists and see patients from birth until about 18 years of age. And so our experiences and resources might not reflect that of your practice and where your resources are in your center, state, hospital system. That being said, we both feel like even with the kind of large city that we work in, there still are barriers to accessing care that we feel and try and kind of work around every day. And so again, hopefully some of our experiences that we share today can translate to your practice.
So now we're going to look at some examples of how this does play out in practice, and we've selected 3 specific cases. So I'll be presenting the first one, and I chose this case because it really shows the impact of an unknown maternal diagnosis. So this patient came to our fetal center about halfway through her pregnancy due to multiple congenital anomalies, but we didn't have a full really idea of what all was going on because a lot of the imaging was really limited by body habitus, but we did have some views of the brain that looked concerning for monoventricle or somewhere along the holoprosencephaly spectrum. During the session, the patient reported that she has 2 other children, a son and a daughter, who have autism, hearing loss, and something in their brain. She couldn't recall specifically what, but she did mention that they were seen at our hospital. She also reported that she herself had an MRI at age 16 that she thought was abnormal, but she wasn't quite sure for what. And then for her own health history, she reported difficulty with learning. So she reported that she had completed some high school in normal classes, but she didn't graduate and she had just lots of difficulty getting through school. And when interacting with her and her partner during the genetic counseling session, I did start to have concerns about her cognitive capacity. So this is the family history that we had taken. So I had concerns that there was maybe a shared genetic etiology in the family. I suspected that the mother herself had mild intellectual disability. And so that got me thinking about most likely dominant or possibly X-linked, although that was less likely. Now, the thing that really saved the session was the fact that her children had been seen within our same system. And so she gave me verbal permission to access their charts, which allowed me to confirm that both of them had shared a 1.7 megabase deletion on chromosome 13, specifically overlapping the ZIC2 gene, which is one of the holoprosencephaly genes. So I then got a lot more suspicious that this was also going to be the cause in the current fetus, given our suspicion for a holoprosencephaly variant. So these were some of the specific gaps that we needed to address in this case. One of the most stigmatizing was the perception of the patient as non-compliant versus her actually having reduced capacity due to her own unknown at that time genetic diagnosis. There had been no prior parental testing to look at the inheritance of the deletion. And because she was unable to recall her children's diagnosis or what testing had been done, if we didn't have access to that EMR, it would have been a really long, drawn-out process and much less efficient genetic counseling initial consult. So we started with addressing the parental testing. So while the mother was uninsured outside of pregnancy, she did have Medicaid. So we were going to start with testing her for a couple of reasons. One is that her partner was uninsured, but also based on his reported history and interactions with him, I felt it was also much less likely that he carried the deletion. And we were able to confirm that she had the deletion as well. Like I said, because of her own genetic diagnosis and lack of documentation that she had personal access to, she wasn't a very good historian about the specific things that I would need as a genetic counselor to help make sure that testing and recurrence risks and all of that were up to speed. So for her, we had written a family letter and provided her with a copy of the results and really emphasized the importance of sharing this information with future medical providers, both for her own providers as well as her children's providers, and really emphasizing a very basic message was that you and your children all have a genetic diagnosis, and here's the information on that. The other gap we needed to address was this perception that she was a non-compliant patient, which was documented multiple times in her children's medical charts. So telemedicine is getting a lot of attention now because it can break down a lot of geographic barriers for patients. But for this patient, it was not a good option because she had difficulty following the multi-step instructions for logging on for a telemedicine visit, and she didn't have reliable home internet. So what we were doing instead was trying to, as much as possible, arrange her in-person visits in conjunction with visits that her kids would already be having at the hospital to reduce the burden and the travel challenges with that. We also did a lot of education, both for her obstetric providers and the providers working with her children, about her own diagnosis and trying to reduce that stigma, as well as involving social work to, again, try to build more support around her and strategies to help her follow through with medical care. Because in talking to her, she was very invested in her children's health and care. She wanted to know what was going on, and she was very motivated to do everything that was medically recommended. She just had cognitive challenges that made it hard for her to remember and to follow through with instructions. She also shared from a psychosocial perspective that the diagnosis was extremely validating for her. And I remember her telling me, so you mean that this doesn't mean I was just lazy in school, that my brain actually worked different? Obviously reflecting things that she might have heard from friends or family members or teachers. And so realizing that she had done the very best that she could, but she had different needs than her peers that weren't adequately addressed in schooling. And now I'll pass it off to Emily for the second case.
Thanks, Lauren. So for Lauren's case, she kind of started off in the prenatal setting, and it quickly became a transition to pediatric and adult care. I'm going to start off with a presentation in the pediatrics clinic where we transition the other direction. So my case actually starts about 10 years previously. So two siblings had come into the pediatrics clinic with global developmental delays and dysmorphic features. And through genetic testing, they were found to have an unbalanced translocation. And parents were tested, and mom actually carried the balanced translocation. To give a brief primer on translocation, so translocations occur when a piece of one chromosome breaks off and attaches somewhere else. And so you can have a balanced translocation where the pieces just kind of switch places. Seen here in the green and yellow, you can see that all the information is there, but just part of yellow is now on the green chromosome and part of the green chromosome is now on the yellow. You can also have unbalanced forms shown here in the bottom right, where there are extra or missing pieces. So we have too much yellow and not enough green, and unbalanced translocations can cause major health issues. And the main takeaway is that a person with a balanced translocation can have a child with an unbalanced translocation. So if we go back to our family, you can see this is the family tree. So mom in light blue is the carrier. There's the two affected children. And there's also an older sister who is quite young at this point, and is healthy, but she could be at risk of carrying the balanced translocation. Now, the easiest way to know that would be to test her, but she's, again, only 7 at this point, and genetic testing is not recommended for carrier status for minors because it takes away, their autonomy and decision-making in deciding if they want that testing. So ideally, she should go and see someone in about 10 years, but what will her life look like in 10 years? Will they live in the same place? Will she have insurance? It's a long care gap, and one that is very challenging and happens often quite a bit in our pediatrics clinic. But if we fast forward 10 years, the original two siblings do return to the genetics clinic for routine follow-up. And sometimes in our pediatric space, we see a patient maybe once or twice, and then we send them off to other specialists and they don't follow up. Other times, for more rare conditions, we actually do like to follow up routinely, partly because there's more information that we have down the road, as well as engaging those siblings and family members, such as our patient's sister here. So luckily for us, the now 17-year-old sister actually attended the appointment with the siblings and the mom. And at this point, she had public health insurance, but after age 18, she was at risk of losing it. So we provided some initial counseling about carrying the balanced translocation. And then because she saw the same pediatrician as the siblings, we were able to coordinate a referral with the pediatrician to just have her establish her own appointment in the genetics clinic, as opposed to trying to figure out if there was an available provider that could do prenatal or adult counseling in our area. And so she was able to come back a couple months later, and she was 18 at that point, and she was found to be a carrier. So again, we provided some initial counseling about reproductive risks and how to find a prenatal genetic counselor when she was ready to start a family. Luckily for us, our teen in this case was very motivated, and she was not sexually active, and she was really invested in learning about her reproductive risk, which helps with these conversations. So for some different gaps to address. So first, teenager reproductive risks. So oftentimes we find that a patient's family member might be a carrier, but it's hard to balance preserving a minor's autonomy for carrier testing with also the knowledge that teenagers can and are having sex. And so when do you offer that testing? Are you able to offer that testing? Especially as they transition to adulthood, can be very tricky. And then that transition period, like we've talked about, has a lot of gaps with insurance coverage, and access to adult and reproductive genetics might be limited. So for our strategy, so referring teenagers to genetics. So whether that's a patient that has a genetic condition themselves and has not been to see genetics in a while, or if it's a family member of a patient that might be at risk, referring them before they enter adulthood can be helpful for reproductive counseling, as well as to give the family some repeat exposure to genetics concepts. Also including, next.
Sorry.
No, you're good. Also including siblings and other family members from the get-go in conversations can be very helpful. It reduces the burden of having just one family member learn everything, and really introduces the concepts of this is a genetic condition that might affect multiple family members. And so I often feel like the counseling session goes better if there is maybe another family member that's there with parents for the initial counseling and as they come back. And again, starting the conversations early before they transition to adulthood can be very helpful. Also, as a pediatric counselor, I'm not providing as much or nearly as in-depth preconception counseling as my prenatal counterparts. But I think that whether you work in genetics or a specialty or even in a primary care office, you can provide some just very basic preconception counseling, and you don't have to worry too much about specifics. Just saying that there might be something running in the family might be enough to get that family in the door with someone that can talk about it in more depth. And if you do work in a specialty clinic that you've received a referral or a patient from genetics, oftentimes genetics notes have some really detailed information that could be useful too. And then luckily in our outcome, our patient was able to establish her own care. She didn't have to travel and navigate a new system that she was not used to, and she was able to get the counseling she needed to go off into adulthood.
So now I'll present our last specific case. So this is one to demonstrate how the different life stages can overlap, and that a pediatric genetic diagnosis can have immediate medical management impacts on other family members. So in this case, a woman's son was diagnosed with the metabolic disorder OTC deficiency, which is X-linked. So males are more often affected than females and more severely, but females who carry the mutation are at risk to have life-threatening symptoms, particularly around pregnancy. For males and children affected, the symptoms can be life-threatening and cause kids to go into a metabolic crisis, getting really, really sick if not caught and treated. So during this disclosure visit for the son's diagnosis, the mom disclosed that she is 10 weeks pregnant, and that was incredibly scary for that pediatric team because she could be at risk of a metabolic crash after delivery. So now we have a very time-sensitive situation where we need confirmation whether she's a carrier or not as soon as possible. Luckily, she lived within the state of Texas. She was insured, and the team was able to connect her really quickly with the reproductive genetics team by directly reaching out to them to facilitate the referral. So this is a family now where we've gone from just a general results disclosure to needing services by multiple specialties in a really time-sensitive manner. So the thing that was most helping bridge the gaps here was really leaning heavily on our network contacts to facilitate the referral, the scheduling, and proactive transfer of the relevant records. So minimizing as much of the time delays as possible and making sure that the receiving service was aware of the urgent nature of the referral. But this patient lived in a very rural area. So, and it was very distant. It was a couple hours away from the main services and places where she accessed care for her son. So we thought about utilizing telemedicine as much as possible for her initial consults that didn't require any sorts of physical examinations. So things like the initial genetics consult and the initial maternal fetal medicine consult for her. We also thought about, and these might seem like really minute details, but they make a big difference in terms of follow through of what is the easiest way for her to get testing. And so because she lived in a rural area, she was at least 20 miles from the nearest location that could draw blood that wasn't Quest or LabCorp, and that's often needed for patients with very specialized testing. So we decided that the best reduction in overall cost and time burden without compromising test quality was to directly ship a saliva collection kit to her home that came with a prepaid mailer. All she'd have to do is drop in a FedEx box, and then we'd call her with the results. And then she also needed now no longer a low-risk pregnancy, but a high-risk pregnancy once she was confirmed to be a carrier. And so that's needing to transfer care to a maternal fetal medicine specialist and being able to deliver at a hospital that's more equipped to care both for her and for a child that could potentially have OTC deficiency. And during this time, we were also able to give her dietary guidance to start the recommended modifications prenatally to lower her risks. And these are also things that she will now need to use long-term. So fortunately, the outcome here was a safe delivery. She did have symptoms after delivery. And so because we were able to get her in to deliver at a hospital that had a specific metabolic genetic service and an OTC labor and delivery protocol, those symptoms were caught early and we avoided her going into a complete metabolic crash. And then the baby was also able to be tested for OTC deficiency immediately at birth by the pediatric genetics team. And I believe, if I remember correctly, that baby was also affected. So while this patient will need ongoing adult and metabolic genetics care later, in the short term, working together between the pediatric and reproductive teams, we were able to bridge the gaps for the most immediate and possibly life-threatening needs. So now we're going to go into wrap up talking about some common themes and also other general strategies that maybe weren't highlighted in some of these cases. So if you've been paying attention, you'll probably have noticed some recurring themes around insurance coverage, physical access to services, the timing of referrals. The other one we touched on more briefly is the consideration of who is the proband versus who is a family member across different specialties, because that's going to change. And that does affect how to navigate HIPAA, the clinic processes on scheduling and sharing records. So for example, if Emily is seeing a child in clinic, he or she is the proband, but if their parents need reproductive counseling, she has to refer a parent. And even though the affected child is her patient, is there anything that she can do to sort of get that process going within her scope of practice? Like, could she order targeted variant testing on the parents to get that started while they are accessible? And then that allows the most informed initial consult with a reproductive genetic counselor like myself. When I receive the referral, the parent is my proband and the affected child is a family member. They have different medical record numbers. And so I can't access anything about the child's chart to inform my consult unless I have a release of information signed. It's also, I think, a reminder to make sure that you are as inclusive as possible in your practice and make sure that your clinic staff and the referring providers are aware. So specifically for reproductive care, that we see males, we see non-carrying partners, we want them to have equal access to services, even though our clinic staff and our referring providers are most familiar with referring the person who either is pregnant or who can become pregnant.
So we wanted to go through a few different other strategies and tips and tricks that we have found helpful in our practices. Some of these might be more applicable if you are a genetics provider yourself. Some might be more geared toward a referring provider or primary care provider, or even a family member. Something that has been very helpful, I've found, is providing counseling letters. So if you're a genetics provider, giving a letter to families or other healthcare providers about a diagnosis can go a long way. So studies have shown that the shorter the letter, the better. And a really important part of the letter is the contact information. So make sure that if you are providing a phone number or email address, that email and phone works for a long time. Make sure that is someone that if a person got that letter, they know and are easily able to contact someone that knows what's going on. There are some online resources and letters available through some genetic testing labs. There's also some websites that are geared toward family communication. And then I always like to include a copy of the test results with the letter. So I'll usually print some off and say, this one test result is for you, and this one is for you to give to your family members, to give to their doctor, wherever they might be. If you are a provider that is trying to get in contact with someone in genetics, or trying to refer a patient to genetics, and it's a really long wait time or really hard to get in, you might consider looking into telemedicine clinics. These might not be the most financially feasible for every patient, but these are clinics that have come, I think, and more in the forefront after COVID, with just increasing access to genetic services. Just make sure that you are referring to a licensed and credentialed provider. And then use your network. So a prenatal counselor in your city might not be able to see your patient for their indication, but it's a pretty small field. We all know each other. And so they might be able to connect you with the right people, or maybe bridge some of those gaps in the systemic process to get you in touch with someone sooner rather than later. Also utilize MSRGN as a way to access your network and expand it. As Lauren mentioned, we are doing a lot of back and forth between the genetics specialties. And so I think this more broadly for anyone in healthcare, warm handoffs go a long way. So instead of giving a phone number to a patient and say, call this clinic to make an appointment, maybe reach out to the referring provider and say, this is what's going on, give some context. If you have a release of information that you can sign beforehand, that will go a long way. And just taking that extra step might be very helpful, especially for patients that might be overwhelmed with navigating the healthcare system or have a lot going on. If you're working in a clinic and you're trying to access genetics, there are sponsored genetic testing programs to get the ball rolling. There's a lot of great folks at genetic testing laboratories and customer service that can talk you through how to order, test, and patient payment plans. There are also research studies that are going on to increase access to genetics in rural areas and other underserved populations. We've already talked a lot about counseling teens with genetic disorders, so I'll skip over that one. But as Lauren mentioned too, don't forget about males and non-carrying partners, whether you are a provider that's referring to somewhere, don't forget about them, as well as if you are a practice that will see those males, try and advertise that that's something that you are able to staff in your clinic. And then lastly, just be aware of your own biases and assumptions. So your patient might have a lot of social factors that have prevented them from getting genetics care. We've talked a lot about kind of the barriers on the healthcare side of things, but there's also a lot of social factors and social barriers that our patients come with when entering the healthcare system. And so don't assume that someone with poor health literacy or a high no-show rate might not want to see genetics. They might want to, but there's just a lot going on that we don't know about. It might be more challenging for them to see us. Next slide.
Yeah, I was going to say the other thing is to not assume that just because your patient has limited financial means or low SES status doesn't mean that they couldn't find a way to cover testing. So you really need to engage with them in the process to see what's possible for them.
So in sum, navigating a geographically, institutionally, and specialty fragmented healthcare system is very difficult, but we know that individuals with genetic disorders and their families have the best outcomes when they have consistent care across their lifespan in those different life stages. So look for creative solutions, develop networks and allies. It really does take a village. We can't fix our healthcare system by one person, and maybe in the future it will be a different landscape. But for now, bridging the gap for one family really can be life-changing. So if you hold someone's hand a little bit more or take that extra step, that can really make a difference for families.
So we'll now transition into the Q&A portion, but just to provide a list of the references that we used in creating this presentation. And now I will stop sharing.
Thank you, Lauren and Emily, for that wonderful talk. We do have several questions already, but for those of you listening, if you do have a question for our speakers, go to the Q&A tab within the attendees website. So we do have several questions related to the genetic counseling shortages that you showed at the beginning. Some people were wondering whether those numbers factored in telehealth GCs licensed in multiple states or GCs that did remote counseling.
Yeah, so those numbers provided are from the National Society of Genetic Counselors. That's the survey that kind of goes out every year that people self-report where they're practicing. So it doesn't include those outside of our Mountain State region that might be licensed in a particular state or able to see those providers. I think telehealth is something that our field is still trying to figure out how to capture and integrate into the typical healthcare system. So hopefully in the future, we'll have some more information about how that might impact the genetic counseling service, and in particular in our region too, which is so vast and geographically challenging.
Yeah, and mostly we had wanted to use those slides just as a sort of global representation of what kind of we in the field know, which is that there's unequal distribution and certain states are much more highly resourced, or certain cities are much more highly resourced than others when it comes to genetics providers.
Great, thank you. Someone else asked, aside from the shortage of counselors, are there any initiatives industry-wide to address the lack of services to minority and underserved patients?
So neither of us work in industry, so I don't know that we're maybe the best people to speak to that. I do know that the field as a whole is very aware of underserved populations and the sort of the strata of who is able to access genetic counseling. And so, for example, like clinically, we have genetic counselors in our city embedded within some of the public hospitals. So they primarily see minority and under-resourced patients. But the most that I'm aware of are really either research studies going on to define the scope of what that need is, which is the first step in addressing it, getting input from stakeholders, so people in those communities, as to what value do they place on genetics, what are their barriers, what are their needs to be able to access services, and then hopefully taking that next step forward and building out programs from there. But I'm not aware of industry specific policies.
Yeah, I was just going to add that I think institution specific kind of processes are, it differs from place to place. I know at our hospital, we have research studies and some different physicians that are trying to do certain outreach. So we're in Texas. Texas is a very large state. And so a patient that is seen in, El Paso or closer to the Valley of the Mexico border, they might not have as much access to genetics providers. And so there are measures that are trying to be able to establish clinics there, even if it's once a month or once every few months, or telehealth in order to see these patients. But I think that a lot of the groundwork is coming from individual practices. And like Lauren said, neither of us work in industry, so I'm not as familiar with kind of what's going on in that side of things.
Great, thank you for those thoughts. And I guess I can add a little bit about industry. I had a rotation there, and a lot of the industries or labs do offer genetic counseling telemedicine. So that's been really helpful for patients who live in more underserved areas. And I've also heard that some of these commercial labs do have like field genetic counselors or things like that as well, that kind of visit these under-resourced regions and help increase awareness about genetics. So there are some efforts from the industry side as well, but I agree with both of you that academically it's really more looking from a research lens.
Mm-hmm. And I'll just add on to that, which is that, those laboratory genetic counselors who are providing services as part of the testing, in my experience, it's really been more focused on once patients have had a test sent in and helping with the results disclosure and understanding of the results. So that can be really helpful for tests coming from, a more primary care office or offices that are maybe specialty, but they don't have a genetic counselor embedded within them. But I think the limitation is that doesn't really address the patients being able to get in for more specialized evaluations.
Exactly. So we have a couple questions related to the cases that you presented. So one person was wondering why there was that wait to turn 18 versus 17. And they said even at 6 years old, if there are not a lot of reports of stigma in kids with carrier status, is it paternalistic to make them wait until 18?
Really great question, and something that I feel like I think about too. For our case, our patient just happened to turn 18 in the time that it took to get the referral and appointment set up. So it was just luck of the timing. That being said, I think the ACMG guidelines for testing of minors, there's a lot to consider from like an ethical standpoint of whether you should go ahead and test a family versus wait until a patient can provide assent or consent. I think it's something that I've heard rumblings of a more debate more recently of should we adjust that, knowing that we're doing a lot of genetic testing now and we're doing exomes and genomes in children and we might find out carrier status incidentally, that kind of thing. So I don't think there's a perfect answer to that, but I do think that it at least in my practice, it varies case to case where we're at in how motivated the family is to get testing. Will that affect the child that might be a carrier? And if they are coming back to see us when they're in their teen years and can assent and are wanting to do that testing, can we go ahead and start that process? So I think it varies, but it definitely a good question and something that I think our field will be addressing as time goes on.
And I just, because I know we're close to time, I have a different perspective as a reproductive counselor where I disagree in general with the restriction to 18, because from my perspective, I've seen enough teen pregnancies where there's a specific genetic risk. And when they show up and they're already pregnant, we're behind the 8 ball, And so my personal perspective is at the very least, as soon as someone is of reproductive age, they should have access to carrier testing and screening. It does depend somewhat on the maturity of that individual to understand, but I don't think we should if you're old enough that you could be having sex and have that result in a pregnancy, then I think you're old enough to know your carrier status and get the same rights to be acting in advance and acting prospectively on that information rather than locking you into playing catch up once something already happens.
Great. Thank you so much. It's been wonderful hearing the perspectives from the prenatal and pediatric experiences throughout this whole talk. And I really appreciate you both taking the time to share your expertise today. Thanks again.
Thank you.
Thank you.
For more information, visit mountainstatesgenetics.org/contact. This activity was brought to you by Mountain States Regional Genetics Network. Please enter this code in the evaluation survey in order to claim Genetic Counseling CEU GS23-08.